Hi guys, it's Sophie from In the Mess. In this video, we're going to run through what to do when you get asked to see a patient who's acutely confused. So when you're asked to go and see a patient with an acute confusional state, you should do the same initial assessment that you do for every acute illness, which is an ATE assessment. It's always worth just checking the patient's airway when you walk in the room for anything immediately life-threatening. You should do an examination of the chest and cardiovascular system, looking for anything that might be contributing to delirium, such as causes of hypoxia, pneumonia, and you should look for cardiovascular causes as well, such as heart failure. In your C assessment, you can also look for signs of hypotension, and you should do a hydration assessment to see if your patient looks dehydrated. When you move on to do your disability assessment, you can do a formal assessment of cognitive state, something like a 4AT, an MMSE. Always worth doing a quick GCS as well, and if you're concerned about someone's cognitive state, a quick neuro exam just to check for any focal neurological deficit. While we're doing D, don't ever forget glucose. Easy to fix, very easy to forget. When you move on to your E assessment, think about examining the abdomen, and as part of this, remember that for these patients, constipation or urinary retention may be the cause of their delirium, so it's worth using a bladder scanner to check for urinary retention and doing a PR exam to look for any signs of fecal impaction. During your examination, look out for any sources of infection that might be contributing to the patient becoming confused. Once you've finished your initial assessment, consider taking a collateral history from the patient's next of kin, a relative, a friend, or a neighbour who knows them particularly well. They'll be able to tell you whether there's been a change in their cognition level and whether this has happened fairly acutely. It can be difficult to tell delirium apart from dementia, but generally, delirium has an acute onset and a fluctuating course, so it may change throughout the day, whereas dementia tends to be progressive and may show signs of deterioration over a longer period of time. Delirium tends to happen to patients who've got a vulnerable brain, so they may have had delirium before, and you can also get delirium in patients who've got dementia. Things that may precipitate delirium include infection, metabolic derangement, hyponatremia, hypernatremia, hypercalcemia, hypocalcemia, dehydration. Things like hypoxia can also contribute to acute confusion, which may be due to an intercurrent illness or a pulmonary embolism. Medications can be quite a significant cause of delirium, particularly things like opiates, but also a lot of anticholinergic medications. Tablets prescribed for overactive bladder, pain, neuropathic pain in particular, or to manage agitation or insomnia can be particularly bad at causing delirium, particularly if co-prescribed with each other. Rationalise all the medications and think about whether things such as antihypertensives or diabetic medications need to be reduced, as the requirement for these often reduces as people get older. One indication for this might be if you do a lying and standing blood pressure and you see that there is a postural deficit. It might suggest that your patient's blood pressure is too tightly controlled, and this can contribute to hypotension and delirium. Occasionally, withdrawal from drugs or alcohol can be enough to precipitate a delirium, so think about whether anything has been stopped recently that might be the cause of the change. To investigate a patient with an acute confusional state, start with a set of blood tests looking at their full blood count, use knees, bone profile, LFTs, and CRP for signs of infection. Consider also taking blood cultures and cultures to look for source of infections such as midstream urine. Consider doing some imaging, including a chest x-ray to look for pneumonia, particularly aspiration pneumonia, as this is something that a frail elderly person might be vulnerable to. If no cause is found, or if there are concerns about head trauma, it might be worth doing a CT head to look for a subdural contributing to the confusional state. However, a CT head might also provide evidence of your vulnerable brain, showing cerebral atrophy or small vessel disease. When managing acutely confused patients, the most important thing is to ensure that we've got reorientation of the patient to time and place to make them feel safe. This can be done in a variety of ways, from simply telling the patient where they are and why they're in the hospital, providing things such as clocks on the wall, calendars with a date and time, and clear signs for the toilets can be enough to help a person be reorientated. You want to make sure that there's good lighting during the day and that they've got good footwear and access to walking aids so that they can get up and about. You also need to make sure that the assistance buzzer is close to hand in case they need anything. You can also use somebody's family to help reorientate them to place and time. People will feel more safe and secure if they hear from their own family or friends, either over the phone or in person visiting. And many friends and relatives are more than happy to be invited into the hospital, even overnight. From a medical point of view, it's worth considering whether an adult with incapacity form is appropriate to allow you to do medical investigations and treatments, although this needs to be done by a fully registered doctor. Consider proactive deprescribing to get rid of any medications that might be contributing to the delirium. Treat constipation with good diet, hydration, laxatives, and keeping your patients mobile. If you think your patient is dehydrated, consider giving them IV fluids to rehydrate them until you can get oral hydration established. However, it's worth being aware that catheters and IV lines may be quite stimulating for the patients and cause worsening of their confusion, but also provide a trip hazard for patients who are wandering. At night, try to keep the rooms dark and provide good sleep hygiene for your patients. You need minimal disruption for people who are at risk of delirium. People at risk of delirium often do better in their own environment, so consider keeping them at home as much as possible to reduce the disruption caused by hospital admission and institutionalisation. If you've got someone who is at risk of delirium or confusion, hand them over to your night shift and day shift colleagues so that they're aware of them. Sometimes delirious people can get quite agitated, and you can be asked to think about sedation for these people. In general, we want to avoid sedation as much as possible. Often sedating these people can be dangerous, as it can make them more agitated or more likely to fall, and often you're just pushing the problem to later on in the day, as if you sedate someone during the daytime, they'll probably be up all through the night. If you've got a patient who is at risk of harming themselves or is presenting danger to any of the staff, then sedation may be appropriate, but you should always get a senior involved to do this. We start with oral medications, and sometimes things like quetiapine or risperidone can be quite useful if a patient will take it, but we can use benzodiazepines as a backup. In an emergency, as a last resort, IM lorazepam can be used in this situation, but this should always be done under the direction of a senior, such as a medical registrar or consultant. So in a nutshell, for acute confusional state, think about urinary retention, constipation, pain, infection, and don't ever forget blood sugar. Don't forget to like and subscribe so you never miss a thing.